Good afternoon, everyone. Thank you for coming to today's KGRI, Keio University Global Research Institute lecture series. And today we have Dr. Schmidt from Lund University in Sweden, and his lecture title is Aging, Health and the Environment, from Research to Practice and Policy. And first of all, I would like to introduce about Dr. Schmidt a bit. He is an associate professor of medical psychology and the scientific coordinator at the Center for Aging and Supportive Environments, CASE, at the Department of Health Science, Faculty of Medicine, Lund University, Sweden. And he received his PhD in medical psychology in the USA in 2005. And before moving to Sweden in 2010, much of his work was related to chronic disease prevention and management with a public health and policy focus, including working as a scientist at the Centers for Disease Control and Prevention. And since coming to CASE several years ago, Dr. Schmidt's research has focused on relationship among the environment, health and function, and psychosocial factors in the aging population. Taking a public health approach using multi- or interdisciplinary teams, he applies methods from clinical trials, epidemiology, and health economics modeling. To increase the impact of research projects generally include collaboration with knowledge users, for example, government agencies, policymakers, industry, older people, and etc. An ongoing research project focus on several environmental factors, housing, including neighborhoods, public transportation, and use of technology across generations. And today he will give some lectures about starting with an introduction to the Interdisciplinary Center for Aging and Supportive Environments at Lund University, Sweden. And he will describe strategies used to develop and conduct research with high social relevance for the aging population. And past and ongoing research project will exemplify how the integration of knowledge users throughout the research process can facilitate the implementation of findings into practice and policy. And empirical results from several projects will be presented with a focus on the relationship among the environment, health, and well-being. Thank you from me, and I will pass the microphone to him.
Yeah. Thank you. Thanks. I appreciate being invited. It is indeed an honor. And I'm glad we also have some guests from outside the university who are joining us today. That is appreciated also. And also to thank Professor Ikagi for inviting me here for this 2-week stay, and Yukie, who I've now been working with for about 2 years. It's been a very good experience, and hopefully I will have future visits back here. So, but first I want to let people know where I'm coming from. I can't assume everyone knows where Sweden is, so I wanted to show a map and show where I am. So we have Sweden up here in the very north of Europe, and then traveling over to Japan. And I'll come back to this map a little bit later, and we'll add some additional details related to maybe some similarities and differences between the two countries. Just to give an overview, although Yuki already provided much of this, since this is my first visit here, I wanted to introduce our center and tell a little bit of background beyond just the research that I'm doing specifically, mainly because I think we have a lot of shared interest and there's other potentials to collaborate with other partners within our center. I'll talk a little bit about aging in Sweden and Japan as our center, and most of my research all the way back even before my PhD studies focused to some extent or another on aging and gerontology. Then we'll talk a little more specifically about aging and health, a little bit about what is kind of some normal things that happen in aging. And then I'll really get into kind of the heart of what I want to talk about today, and that's related to home and health. And we'll take in two main aspects of the home environment and how those are related to health, one being temperature and another being the accessibility of the physical environment. And then finally, I'll try to tie some of that together to get back to the main topic about how we at our center try to get our research into practice and into policy. And a lot of that is through user involvement in our research. And hopefully that will become clear as we go. So CASE is the Center for Aging and Supportive Environments at Lund University. It's been around now for about 11 years. And I'll tell more of the details of it a bit. It was originally funded from Forte, which is one of the Swedish research councils that provides grant funding. And it was funded for a 10-year period in order to really strengthen the aging research at Lund University. And they also funded a second center at Karolinska Institute in Stockholm at the same time. And we've worked together across this 10 years to really start to try to strengthen the aging and health research across Sweden. We have some main goals, and really it's really about creating societal change. It's not just about doing our research and publishing it and then letting it collect dust on the shelf. We really want the research to get out there and be used. So that's been a main focus since the beginning. We want to enhance healthy and active aging in Sweden and beyond. And as I show a bit, we have many international partners over the years. And when I talk here about healthy and active aging, we sometimes take a different approach to how we define healthy and active aging. When we think about health, it's not necessarily the absence of disease, which some definitions of health often include the absence of disease, but we take more of a functional perspective. So as we age, we're all going to get sick. We're all going to have diseases. And so in our center, we really focus our projects not necessarily on the disease, but on the ability to continue functioning despite having a disease. And active aging often has been interpreted to mean physical activity, and there again we take a much broader perspective to include social activity, other activities that people find meaningful in their lives, and that can include also physical activity as one component. But I want to be aware that we really take this much broader perspective of what is active and letting each individual decide what is active for them. Just to give one example, some early work that we've discussed and worked on talked about, well, older people like to remain social, but as they age and maybe their spouse or partner dies and then they feel alone and maybe their friends start to die, they get this social disconnection and want to engage socially. But now with modern technology, we're finding that it doesn't necessarily mean that they want to go to visit their children or grandchildren who maybe live far away, but they're just as happy to Skype with them and talk to them through technology. So it's socializing can come in many different forms today. And we've been surprised to find that, that much of that occurs in different ways than we traditionally think. We have several missions. One being related to dealing with the environments to support healthy aging. So it's not necessarily about changing the individual, but it's about how can we adapt the environment in order to allow people to continue to function and to continue to age and be active. One way we strive to do that is through collaboration with different types of users. So it's not for us as the researchers to dictate what people should do in order to stay healthy and active. We work with older people themselves, with interest organizations and others to try to identify what it is that people desire in order to stay active and healthy. And we strive to give just kind of positive daily life changes that older people will recognize themselves as important. A second important level is of high societal relevance. So things that are practical to be implemented within societal planning. So we don't want to, so we also then work with these types of people as users. The people who will be doing the planning, the people who will be doing the designing, the people who will be offering the services if it's in a healthcare setting, to make sure the things we're testing and trying could be practically implemented, rather than getting to the end of our research and then finding out that, well, it really worked nice, but there's no way it can work within the Swedish healthcare system, for example. And then, of course, we strive for impact on policy and legislation, and I'll talk much more about that later in the presentation. Okay. We have several research themes going back over the 10-year period. So we have this healthy aging again that I've already described. It's not necessarily the absence of disease. In some cases, we do strive for disease prevention through changing the environment, but it's also to allow people to continue to function despite disease. Under that, we have other focus areas. So aging and housing probably being our largest theme over the past 11 years. Aging in public environments, so studies related to walkability of neighborhoods, for example, the use of public transportation, and then also cycling. I'm not going to talk so much about those today. Maybe if we have time at the end, I could mention more there. But to let you know that these are areas where we have done considerable work, because we also think of the home environment encompassing more than the home, because we need to be able to get to community services, to get to the places where we want to engage in meaningful activities. So then we also take into account the neighborhood environment, other public environments that may require a bus or a bicycle or a car in order to get there, or just walking. Aging and disability is a third theme. So there again, it's more this health perspective that we take two alternative approaches to that. One is aging with a disability. So once a disability occurs, how does that affect the aging process, and how can we interact with the environment in order to make that better? And then the other is, how can we adjust the environment to prevent disability? So we take two approaches there on that theme. And then a more recent theme is research with and about user participation. So from the Swedish government now for a number of years, it's been promoted as well as at the European level for European funding to have user involvement more so in your research throughout the research process in some way or another. And it's been assumed that this is always good. But what we've done now is we've started a separate research theme where we will actually try to test this to see, is it good to always have users involved in all aspects of research? Or are there certain places it's more valuable and other places where it's maybe not appropriate due to conflict of interest or other things like that? Because some of the users we work with may be developing products, so there's profit involved for them. So how involved can they be in the research when they may have a bias already because they're looking to make a profit? So trying to find a balance and develop strategies where you can effectively do that without influencing the results in the wrong way. That's a relatively new theme. We've just started this on a new grant over this last year, so I don't have data to present on that, but that will be a theme over the coming years. Oh, I just added a circle down there. And that is one example of one typical Swedish house, probably built between 1950 and 1970 time frame. It's not the typical Swedish red farmhouse. Those were usually built earlier than that time period, although you do still find some of those being built today because people like the tradition. And I'll give some better descriptions of the houses in a bit. The center also takes a very inter and transdisciplinary research approach. We try not to work in silos. So rarely do we have a project that only involves one discipline. And these are just a sampling. I probably didn't cover everything here, but this covers many of the disciplines that we have involved in the center. Overarching, we more or less have a theme of environmental gerontology, although all of the researchers don't always work in the environment. Some specifically work more with the healthy aging without the environmental aspect. Within health sciences, we have occupational therapy, physical therapy, nursing, public health, epidemiology, for example, clinical sciences, rehabilitation medicine, social and behavioral sciences, psychology, social work, sociology. Within engineering, we have experts in public transport, rehabilitation engineering, and also rehabilitation technologies, design sciences, construction management, software engineering. And then we also have elder law involved, because when we're dealing with the environment and potential environmental changes, particularly at the policy level, it usually involves some sort of government policy, some sort of legal rights issue. Sweden has many laws based on human rights. And if we look to try to change something, we have to see how that impacts the current legislation. So over the last couple years, this is a more recent addition, having elder law involved. So as I said, our center was originally funded for 10 years. Now we've moved into a second stage where just in December this past year, the university has more or less just given their endorsement that we can continue as a center. There's no stated funding for that center, but what it is now is more of a network comprising the same groups, plus the addition of elder law and the rehabilitation engineering and construction management are also new additions to this case, although we've actually had been collaborating with them previously. They hadn't been formal members. And then within case, besides the local collaborators, we've had many international collaborations over the years. The ones in red are current collaborations that are ongoing now on different projects. And I've added Iran is new. This is a new one that is starting. We'll be hosting a sabbatical for a professor from Iran for about a 6-month period, probably starting right after summer. And our goal there is to develop some joint collaboration. And then I have the question marks after China because we currently have two PhD students interested in coming to work with us, similar to how UK did a couple years ago, and wanting to come and do a stay with us to learn about our work and develop some collaboration. And then, so as I said, we've been collaborating here since 2015, and then we also just started a new collaboration with Waseda, did I say that correctly? University. One of our other co-workers will actually be coming on Friday and spending about 3 weeks there, and then he'll come again in the fall to do some work with them. And then we hosted a student from there. Well, actually, she had just finished her PhD, so she came as a visiting postdoc. I guess the last time you were in Sweden. So we're having the return visit now. And that's also related to housing issues. Okay, so now I've introduced the center, and I want to shift a bit and talk more about, just in general, aging in Sweden and Japan. What are some of the trends that we're seeing? What can we expect to see in the future? So first, just a little bit about the country. So Sweden has 10 million people. How many people are in Tokyo? Does anyone know? More than all of Sweden, I would guess. Yeah, about the same? Yeah. So in all of Sweden, you have that many just there in Tokyo. And then the current numbers I got for the total of Japan was 126 million. I have these arrows here because the Swedish population is rising and the population in Japan is actually in decline now for several years. This is land mass, just to give you an idea of the size. Not a huge difference. So Sweden has a lot of land to use compared to the number of people. However, our populations are still mostly based in more highly populated areas. Most of the population is in the southern third of Sweden. Part of that is weather. It gets really cold up north. But it's also more accessible from an industry perspective to the rest of the world. Now looking at aging, so for those age 60 and older in Japan and Sweden, Japan has been 1 or 2 for a while, currently in the number 1 place, having 33% of the population being age 60 and older. We have projections going out to 2050 that if things keep going as expected, that will rise up to over 42% by 2050, being age 60 plus. And then for Sweden, Sweden had an aged population in the world rankings. And now it's actually that ranking is going down compared to the rest of the world. So the rest of the world is now aging much faster than Sweden. Although Sweden still has an increasing trend, but as you can see, between 2030 and 2050, it's only expected to go up 1%. Another interesting population statistic down here for the total population by 2050. So Japan is supposed to go down to 109 million from the current 126 million. And Sweden is supposed to increase another 1 million to 1.5 million in the same time period. So some of the reasons for that, the first one being fertility rate. Both Sweden and Japan are below the replacement rate on fertility. And what I mean by that is more people are dying than are being born. And so that is actually the case for both countries. And then related to that I don't have up here, the biggest difference between the countries then is immigration. So Japan has a very low level of immigration, very few foreign-born residents who are permanent residents, where Sweden now is up to about 15% of the population that was originally foreign-born and has immigrated to Sweden. So that's really the big difference, driving that difference of population projections for the future, is the immigration policy in Sweden. One other factor is the birth fertility rate in Sweden was a bit lower. Then some years ago they started a system to increase that because they recognized early that was going to be an issue. So they started providing very generous maternity and paternity leave. So the two parents, the mother and father, get to share about 360 to 380 days of paternity leave that they can take off work and receive 80% of their normal pay during that time period. So it's in, they also provide a monthly allowance for every child that people have. It's not a huge amount, but it helps to buy clothes and other things for the children. And it's been a very proactive system in order to increase that fertility rate, and it seems to be working. And they continue to try to provide new incentives for that. Another thing driving the percentages now of those older than 60 is the life expectancy, where it's going up. So Japan, it depends on which statistic you look at, ranks close to the top in the world for total life expectancy. But what I'm presenting here is just life expectancy for those who reach age 60. Because from my perspective in the research I do, I'm dealing with the older population mostly, which generally means, about over 60. And so once somebody reaches 60, then here we expect women in Japan to live another 28 years. And 23 years for men. Slightly lower in the women for Sweden, and the men are comparable in both countries. So if we make it to age 60, that's about how long we can expect to live. But as we know, and as I talk about when I get to aging and health, that we start to develop different health conditions as we get older. We start to have some physical decline. We can't live forever. So it's a natural part of the life course. And then we come to this statistic we called healthy life expectancy years. And here what this means is the age where you can expect to no longer be in good health. Maybe you have developed some chronic diseases and some functional limitations. And in Japan, that's 78 for women and 72 for men, and both are slightly younger in Sweden. This last here then gives us the number of unhealthy life years. So this is how many years you can expect to live in poor health before death. And this is one of the big focuses for many governments around the world, is how to shrink this number while increasing this number. We've done really well at getting people to live longer, but that quality of life isn't so great always. While we've increased the total life expectancy, we've also been increasing these unhealthy life years along the way. People used to die at a much younger age, but once they developed heart disease, they would probably die within 2 to 3 years of developing that heart disease. Now, due to medications and medical science today, we can live quite a long time, even with such serious conditions. So those are some of the important things driving this. So why is this important here? Because it's a given. We will eventually reach here. We want to shrink that number. There's 2 ways to do it. There may be more, but 2 basic ways. One is you improve the individual health in some way. That's where most of the medical research in the world goes. We're trying to solve diseases, try to fix things. But we are all going to die eventually. We can't cure everything. It will never happen. So the other option is we can accept that we will have some limitations, but then we can modify the environment in some way so that we continue to have a good quality of life despite having these functional limitations. So shift a little bit now to aging and health. Some of these things I've already said. I'll be a little more specific perhaps here. So we know physical performance just declines. We get weaker, it's harder for us to maintain our strength even if we continue doing physical activity and training. When I'm 70 years old, I'm not going to be able to lift the same weights as I could when I'm 50 years old or when I was 30 years old. We're going to have different types of physical decline. Physical decline leads for risk for other things. So your risk for different functional limitations and disability. Risk for falls, risk for frailty. So as I decline, I start to have problems in other areas. I'm at risk for different types of injuries. That may lead to some of the disabilities and so on. We're also at risk for multiple chronic health conditions, such as diabetes and heart disease. Chronic joint diseases are quite common, so osteoarthritis in the knees and so on, which can have a big impact on your functional abilities in later life. Again, our bodies just start to wear out at some point. And again, there's many good medical treatments for some of these, and so that's why we get to keep living longer. But those medical treatments often don't solve all the problems. And then all of this leads to risk for dependence in activities of daily living and poor well-being, including both physical and psychological well-being. But we know, as I already said, that environmental factors influence all of these risks. So this is a model here that we often use with many of our research projects. It's developed from Lawton and Neuhauer, 1973. It's been around for ages. And it was established here as a model, and it's been tested many times and been shown to last. That's why it's still used today. So we have two things. Over here on this side, we have an individual's competence or an individual's abilities. Where am I? What is my health status, my mental status, everything we have here? What am I able to do? On this other side is the environment, or what we call environmental press. It's the pressures that the environment puts upon us. So we have to find a balance between our abilities and the environment, and we have several zones in here that work for us or against us. As you can see, kind of here in the middle, if I have my competence lined up with the level of the environmental press, I adapt to that environment. We're all facing new environments all the time. We're all facing environmental challenges. It could be changes in our competence or changes in the press can move us along this one way or the other. What we need, though, physically and mentally, is a challenge. We don't want no environmental press, or we stagnate. So, for example, if anybody has ever, for physical exercise, you try to strengthen your body or try to run faster. If you do the same exercise over and over and over, you're going to reach a plateau and you're going to get stuck. You're not going to get stronger because the environmental press stays the same while your competence goes up. So if I started with an environmental press here with the training, the environment that I'm training in is the same. However, I'm getting stronger and I'm getting faster, and eventually I end up in this area. And what happens? People get bored with it and they quit. If you think about other activities, assembly line work is a good example. So people, when they start off doing repetitive tasks, say in an assembly line work, they make mistakes, they're not so good at it because they have very low competence. But they start someone out training in a very simple environment. So what happens is they get better and they start to get in this zone. Then the employer speeds up the assembly line. They increase the environmental press so that the person then falls in this adaptive zone. So what do? They get faster and better at doing it. But if they don't get any press, if they keep that assembly line going the same way, the employee gets bored, they start to make more mistakes, they're not challenged any longer, and either they'll just continue to make mistakes or they'll quit the job and try to find something more interesting. So the same thing happens with health. We need to still challenge our bodies. We don't want to take away all the environmental challenges in life. And I'll give some examples of that when we get into the physical environment of the house in a bit. But I just wanted to introduce this here, and I actually will bring that figure back up later. But this is very important to health. So if I'm in a good zone here, and then I have a health problem, and my competence drops, I'm going to fall down into this area. So there's two things to do. Either I improve my competence, in this case I improve the health. If I can't improve the health, then I have to adapt the environment to reduce that press. But I don't want to get rid of the press. That's the key thing to remember. Like I said, I'll come back to that. But for now, let's talk a bit about house and home along the process of aging. I'm not sure in Japanese language, but in English, house and home are often used interchangeably. But from our research perspective, we separate them out. A house is basically, it's a dwelling. It's someplace where you keep your stuff and where you sleep. A home starts to become something that has meaning to you. You attach something to it more than just that physical place where I sleep. So I have fond memories of my children growing up in my home, for example. Or in my home, I have the old furniture that my parents left to me, so I have those memories of my parents in my home. And so it gets a different type of meaning to it. It also goes beyond the physical house. It's the neighborhood. Attached to my home is my next door neighbor who is one of my best friends and who I do a lot of activities with. That becomes part of the home as well. So it's beyond that. And we find that both the house and the home have an effect on health, are associated with health. So home and health a bit. We know that as people age, they spend more time in their home. Maybe now we're all in our working lives. We're not home very much, perhaps. We work long days, we go home, we eat a meal, we go to sleep, we get up and we do it again in the morning. We're not spending as much time there. But as we retire, the home becomes more important for many activities, and we spend more time there. Many meaningful activities occur there, more so as we age. And as physical function declines, this environment can either help people to stay independent, or in my sense, when I say independent, they're healthy, or it can lead to dependence. When they start to have difficulty doing their everyday activities, being able to take care of their home, being able to manage things. This is his home in a variety of pictures. It's one of our other PhD students' father. So again, here's that typical Swedish house. Here it is in winter. We had a lot of snow that year. At least the part of Sweden we live in, we typically don't get so much snow, but occasionally. But that is the same house from the same angle. And here's the front of the house in the summer, a very nice garden, which was very important and meaningful to him. Close by was a lake that he enjoys going to. A little, we call this a summer stuga. It's like a little cabin. It's like a summer house where people go. They're often 1 to 2 rooms, very small. And here's the inside of the home. Lots of pictures of family, children, grandchildren, parents, and so on. It's a sense of attachment, and that has a big effect on health as well as these physical issues. And we'll talk about some of the physical things. So, for example, there's a couple steps to go up here that you can just see. How does an 80-something-year-old man who isn't in the best of health clear away his snow? Things like this. Oh, here you can see that's a better picture of the stairs there. And the access to get to one of the favorite places. As somebody starts to develop functional limitations, how can we find ways to still engage in those meaningful activities? So let me switch now to housing temperature. So I want to talk about that now, and then I'm going to come back and talk about the physical environment more and show some more pictures from there. So there are many factors inside and outside of the home that have a role in health, but as I said, I'm going to talk about temperature on the inside as well as some of the physical structural designs today and not try to cover everything. So just some general background information. So a lot of research has been done in the UK related to indoor temperature, and they've come up with a recommendation that 18 degrees Celsius seems to be the cutoff point. So as you get below 18 degrees Celsius, we start to see more health problems. So increased blood pressure and poor physical performance occur. Most of these studies were done in relatively controlled environments and so on, being able to determine these things. Not always in real world houses. And so that's where some of the research is now, is what happens in real world houses. To give you some ideas of differences between Sweden and Japan, down here, Malmo is about 10 minutes by train or so from where I work in Lund. Lund doesn't show up on the map. And so we actually have, this is winter temperature, this is January. This is the average temperature in January. Most people think of Sweden, oh, it's way up north, it must be freezing and snow covered all winter, but it's not in the southern part of Sweden. It gets a little bit colder as you get up towards Stockholm and then gets quite cold when you get up in the north. And then as we see in Japan, it's a bit more mild. So 5 degrees in Tokyo, 6 degrees in Fukuoka, if I say that correctly, and then -5 in Sapporo. So again, these are January temperatures, just to give you an idea. So certainly up north in Japan, it's much colder even than the southern third of Sweden. There's more variability in the daily temperatures, though, in Japan. So the range from low and high is broader. So for example, down around Malmo, the range is about 3 degrees. So it might be, if the average is 1 degrees, the low for the day might be -1, the high might be +2 or +3. So I didn't have a good picture of the inside of a Swedish house, so this is from my house at my daughter's birthday. So she's in the picture. But what Sweden does, one way to compensate for this in the housing design, is it's not just necessarily the design of the house, but it's also the placement of the house, the angle that it sits in relation to north, south, east, and west. So for example, here, this is my dining room. I have a wall of windows that go from a relatively low, about just above my knee, close to the top of the ceiling. The entire wall is windows. There's another small wall and the living room in the next room with 3 additional windows the same way. These are mostly west facing, so they get the heat of the day. They get the sun during the heat of the day that warms the inside of the house using the greenhouse effect through these types of windows. Besides being well insulated compared to Japanese houses. They are very well insulated also, but high energy cost and other things still dictate having these other creative designs to supplement that. But then if we look at summer temperatures, Sweden is much more mild than Japan. So even in the southern part, the average high in Malmo in, I think, this was August, was +17. And then Sapporo +22, the coolest part that I put on here for Japan. So on the flip side, we don't always talk about the summer heat, or we haven't studied that yet, but that's something that I think we need to consider in our studies. I know it has been studied elsewhere, but we don't have any sort of cooling inside the house in Sweden. So those wonderful west-facing windows are terrible in the summer. I sit in my house and I sweat. So my children and I usually sleep in the basement because it's about 15 degrees cooler in the cellar. So we have an extra room down there with a sofa bed, and we often sleep down there in the summertime because it's just so warm in the main house, the way it's designed. But we open up all the windows and the doors, and that has some effect. But Swedes spend a lot of time outside in the summer. We're usually out in the garden because it's usually much cooler out there. So now let's turn to some of the work that we've been doing together. This was one study here looking at the housing temperature and health in Japan. Here we were looking at different measures of physical strength. And we took several factors into account. One was the season. And then the other was warm and cold houses. So the outdoor temperature was affected based on the season. And then we had indoor temperature reports of warm and cold houses. And so it wasn't a really big sample, but we did find some nice, interesting results still. So we found that for those in a warm house, the difference between this one was grip strength. The difference between autumn and winter wasn't so much. and the difference between the warm and cold houses in the autumn was not so different. But in the winter, you see a much steeper decline in grip strength in those who are in a cold house, or who report colder houses. And then here, grip strength in the left hand, this was the right. We see a similar pattern where they were almost actually identical in the autumn, but the warm group actually went up. That may just be a result of the small sample size, but the cold group, again, kept that declining pattern. So we need to do more of this with larger samples, I think, to really try to replicate this. This was really more of a smaller pilot type study. We've done an additional study that hopefully will be submitted relatively soon, but this is one of the main findings. Here we're looking at risk for frailty, so basically people losing their strength, becoming dependent on others for their daily care and so on. And we found here that there was a big influence of their economic satisfaction, of the economic situation of people. So if you can see this, for those who report being in a cold house and being unsatisfied, they scored much higher on the frailty index, indicating they were more frail. And then there was no difference between the other groups. So the economic satisfaction is quite intriguing to me. We don't know, but we can speculate that it could be if they're unsatisfied economically, they don't have so much money, they're not willing to pay to heat their house, they don't want to pay the cost for the heating, so then their house ends up being colder. And as we know, cold houses are a risk for frailty. So again, that'll be something to follow up more on, but it finds some very nice, interesting findings to start with. We don't have the indoor housing temperature data in Sweden yet. Actually, we do, but we just got it and haven't been able to look at it yet. We have this study here called the Tekkit Home Project, which was designed for a totally different purpose. It was designed to test a different set of home sensors in people's homes who have dementia. The goal was not necessarily to intervene or change anything for the people who have dementia, but it was to give their family caregivers a break. The idea was to improve the quality of life of the family caregiver, so they didn't feel they had to constantly be in the house watching their parent or watching their grandparent or taking care of them. So what happens if one of the alarm goes off, it can send an alarm to the family member's mobile phone and let them know what type of alarm it was and let them know you should check on your relative. And so they can pick up the phone and call and say, hey, is everything okay? We had the water detectors going off. Did you forget to turn off the water in the bathroom? Or they can, if they're close by, they can just go and check on them. But the added benefit was that we also had a temperature sensor in there. So then when we met Yukie, we said, well, maybe we can do some work with our Swedish data. So we've just gotten the data going from May through the end of January. So hopefully we'll be able to look at that soon, I think for 40 to 50 houses so far. The people are followed for 12 months, so eventually we'll have a full 12 months of data for everyone. But one thing I would suspect is we may see what might look like strange indoor temperature readings here. Because again, this year in particular, because Sweden had a very cold summer this year. So it was rare that we had a day above 20 degrees in the part of Sweden where this study was conducted. But Swedes will still open their doors, open their windows, and spend most of their time outside in the summer, no matter what the temperature. They may take a little blanket, put on more clothes, but they like to be outside. So my guess is we will actually have colder temperatures through August than what we'll see through December and January, because the Swedish houses, for the most part, are well insulated and well heated in the wintertime. But I'm really interested to see how that turns out. And then also, is there a health effect during those cold summer months? If we have a cold summer or a cold autumn, will that have some sort of health effect as well? So now I'm going to switch over to housing accessibility, which is really, I can explain the way we consider housing accessibility. It's a mix between the physical environment and the person's functional abilities. So we don't just consider stairs as an accessibility problem. Because if you have no physical problems, then regardless of the stairs, the house is accessible. But once maybe you develop a physical problem, you need a rollator, a walker, or something like that, then the stairs can cause an accessibility problem. But these are pictures from typical Swedish homes. So there's some stairs. These are typical indoor stairs, a bathtub, and then a kitchen. Very, very high cabinets in many cases. Certainly not very accessible if you have some sort of physical problems. People at our center have been doing research on the housing environment and accessibility for many years, going back to this Enable Age study, which I believe started in 2002, if I remember correctly, and it was conducted in 5 EU countries. And in this study, they did in-depth surveys of the home where assessors went to the homes. They spent about 2 hours there. They would take measurements, see how high thresholds were, how wide door openings were, but then they also did a physical assessment to see what were the person's functional abilities. And this was an EU-funded project, which was only funded for 2 time points, a baseline and a 1-year follow-up. But in Sweden, we were able to get additional funding, and we continued with a 5-year follow-up and then a 9-year follow-up also in Sweden. And we still actually now track out the participants until death. We have a handful now that are over 100 years old. We hope to be able to do a small qualitative study with that group to see, was there something special about this 100-year-old group. But I think we're down to 30-something left in the from the original Swedish sample. Because they were all 75 to 89 to start, depending on the country. Sweden was actually 80 to 89. We had Latvia and Hungary as partners, and they had a much shorter life expectancy, so we couldn't get enough people in the 80 to 89 range. So we took a slightly younger sample in those countries. But just to summarize, we published well over 45 papers from these studies. So I don't want to present all that to you, but just to highlight a few things. So accessibility problems, that person-environment fit of that diagram I showed you, are important in old age, but those environmental barriers alone are not. And so that's been a problem we had found working with the construction industry in the past, that they have government standards that tell them, oh, a threshold can be so high, doors can be so wide, and so on. But just doing that alone doesn't mean a person can function in that house, because those are a general standard for an entire country. So when we just looked at those barriers, it didn't predict the different health outcomes. But when we looked at that relationship between the person's physical limitations and the environment, then it was very important. We also found, so that was really about these objective aspects of housing, where I said they did all these measurements and everything and did an objective assessment of the individual. Perceived aspects are also quite important, particularly for people who have a lower level of functioning. So if they perceive their home as not usable or not accessible, regardless of what the measurements say, it still is related to their health. So it doesn't matter what we say, your doorways are all fine, you don't have any thresholds, you should be able to function in your home. Still, if they perceive it, that is their reality, and it affects their ability to take care of their activities of daily living. We see more symptoms and so on. Yeah. More recently, we wanted to look at a slightly younger cohort, so we did a study with people 67 to 70 years old. This was part of a larger Swedish national aging and care study conducted in 4 different sites around Sweden. The GOS is good aging in Skåne. Skåne is the very southern region of Sweden where Lund University is located. And we took a subsample from one of their cohorts. This is an ongoing national longitudinal study. But we did a subsample starting in 2010 of people living in ordinary housing. And by chance, most live in multifamily housing. So I mean, people see often all the pictures of the nice Swedish houses, but still, the majority of people live in apartment buildings, whether owned or rented. Actually, many of these were owned, not so many rented. And so what we found here was that the objective assessment of the home didn't matter so much for this younger group. because they're still mostly physically healthy. But there were these subjective factors. So believing that they didn't have control over their housing situation, over their activity choices. So if their health was perhaps declining, but maybe their children or someone else is making decisions for them, then they had more physical symptoms. So their health was poorer. They had more symptoms of depression, and they didn't feel a good purpose in life. So relating more to their psychological well-being. Also having a low level of connection or meaning to their home. So I talked earlier, I showed that picture of the meaning of home, how living in a home for many years. Swedes traditionally don't move. So it's quite common for someone of retirement age to have lived in the same house for 40 years or longer. And they develop a strong meaning. And again there, if people didn't have that connection to their home, they also had more physical symptoms, more symptoms of depression, and low purpose in life and not feeling autonomous. This was a cross-sectional study, so we don't know which way it goes. Perhaps as they develop more physical problems, their home is no longer usable for them. And so they start to lose that meaning. Because if you can't function and live in your home, does that change that feeling of meaning for you? In some qualitative interviews, they have found that to at least have been reported, that people start to become angry with their house because it no longer works for them. And then also we found that belief that a physical environment doesn't support performance of daily activities. Those people had more symptoms of depression, not necessarily more physical symptoms. So again, it's that environmental fit. People accept that they're going to have some physical problems as they age, but they still want to be able to do things. But when they can't, then they get symptoms of depression. So here's the pictures again and ways to remedy the problem. As I think I've already covered that quite extensively, that we can't always change the individual. We might be able to give them a rollator or a wheelchair or other devices to help with their physical functioning, but those actually are changing the environment as well. They're not changing the individual. Those are environmental aids. But then we can also go in and change the home environment, make it more usable. Or, as an alternative, finding alternative housing that is more suitable. So now, what have we done to actually try to get all of this research to actually be used, to get somebody to do something with it? So several key things we look at is working with government partners, and not just at the end, throughout the research projects, even at the design phase, finding out what do government agencies need, user involvement in research, and then trying to find ways to demonstrate the impact at the societal level. And I'll give some examples of all three of those. So one thing we've done at our center is Sweden has a national government who sets many policies, but all of those policies are implemented for the most part at the municipal level. And there's very few national taxes. Most of the taxes are paid at the municipal level, and then the municipality provides services. And so one of our goals has been to contact and work with as many municipalities as possible. And so over the 11 years of case, we've had contact with 53% of those municipalities so far. Some has been very brief contact, just providing them with information about important aspects of housing or public transportation. Others have been actual partners in different research projects. Also accepting commissions from different government agencies. So for many of the researchers we work with, they want to do their pure research. They don't want to write a report for the government. Because it's not research, it's not going to strengthen my CV because it matters if I got a high impact journal. But we've accepted that it's important to take our time and do these types of reports if we really want our research to be used. So we rarely say no to these types of requests, knowing that it is going to take time away from our research. But then that gets it in the public eye and makes it more likely that it will be used for policy. Users. That's one of the key things that we've really been implemented. And we take a very broad definition of what is a user. We think of anyone who might use our research results in some way or another. So oftentimes users have been thought of as the older people. But we also want to include specific vulnerable groups, but family carers. They're very important to providing the appropriate health care at the right times. healthcare organizations, social services, industry professionals, public agencies, officials, policymakers, and interest organizations and their representatives. We try to work with these as many as possible. CASE, since its inception, has had a user board to help guide what we do. So it's more or less a resource that we can go to and ask, what is relevant right now? What is important to society? And we try to strategically recruit users with the right competence and expertise to cover a variety of areas. So we've had ex-ministers from the Swedish government. We've had a retired minister from the European Commission. We've had people who have run large healthcare services within Sweden, people in the housing industry who, again, our users are usually retired themselves, but they've had some role in relevant to the type of research that we've done. And then they can help us, one, to suggest that we're doing the right thing, we're focusing on the right topics, but they also help us get the results out there. They have large networks. So one we work with is called PRO. It's basically the largest retirement person's organization in Sweden. So retired people can join this, and they have huge mailing lists and email lists, and they can send out information about the work we're doing here. And Sweden has a very big grassroots perspective in getting things done. So the people's voice is heard in Sweden. Town hall meetings are quite common. They're televised all the time. So by getting, this is one great mechanism to get what we're doing out there. And so that's kind of what I've already talked about there. We also go to these town hall meetings. We're often invited to come and present. So there'll be like a Lions Club or something like that, and will ask us to come and present about housing and health. And so we accept those invitations and go. And again, it's one of those things, we know it takes away from our research time, but we think it's important. And then we provide education and training activities. So once a year, we typically have a case day where we'll just open it up, and anybody who wants to come is welcome to come. We talk in a popular science presentations about the research we've been doing over the last year. And we typically have about 200 senior citizens attend that, just in the local area in Lund, as well as people from some of these other organizations. We provide specific training to professionals in different agencies about housing and about accessibility in particular. And then we provide training to future aging researchers. We have a large network across Sweden. We run a national graduate school on aging and health in Sweden that we coordinate. And so we make sure that many of these issues are raised there. And it currently has about 50-something PhD students all around Sweden who are enrolled in that program. One example of user involvement in research was a project called Innovage. Here we developed an app about housing accessibility, and from the very beginning we had users involved in a process called research circles. So here we had older senior citizens, some relatively healthy, some with different types of functional limitations, from physical to visual to hearing. But then we also had representatives from the housing industry. We had realtors, we had builders, we had people who ran construction companies, and they all come and sit together, all of them at the same time, and talk about what are the needs and how can we design, in this case an app is what they decided to design, to help the older people assess their home environment to determine, is it accessible? Because in Sweden, if it's not accessible, you have a right to have a home modification. The government will pay to come in and modify whatever the problem is in your home. So if you need a ramp to get in your front door, they'll come and do that. But many people don't know they have all these rights, and they don't know what to look for. So through this process, we developed an app, and here's just a couple screenshots. One gives you the option, if you identify specific problems in your home, how to change those. The other is still a work in progress, but it's a database of available apartments in the community that have been assessed. And it tells you how accessible they are based on your physical profile. And it can identify, okay, you have a problem with your lower legs, so if you click on that, you can see that, oh, there's 3 stairs to get into the building, so that might be something for you to consider. So it helps people to search for an appropriate apartment for them. We've just started a new project now, working with a housing company, and maybe I have that on this slide. Yep. Where we're now taking that app, modifying it and combining it now with an app for people who run housing companies. Much of the apartment type housing is run by a municipal housing company. And so we're working with one of them now where they will go in and assess all of their apartments for accessibility and put that up when they have an apartment come available for rent. So then the people who want to move in, the older people who want to move in, or anybody, it doesn't have to be older, anybody with a functional limitation can then look at that list of available apartments and know how accessible or inaccessible it is. So in this case, the users become professional users, where the first step of this app development was mostly about the older people themselves were the ones intended to use the app. And then just one last example of the way we try to get at impact. We can do some statistical modeling based on the effect sizes that we found in our research, where we have these environmental barriers and functional limitations, which together determines housing accessibility. So these environmental barriers would be that environmental press that I showed on that diagram, and the functional limitations is the person's competence. And then we get a housing accessibility score. We found that at 1 year, this housing accessibility score predicted people who would become dependent in activities of daily living. We used the effect size from that to then estimate how much home services a person might need once they became dependent in ADLs. And then we did some cost estimates here. So if we removed the 5 worst barriers in the person's home, we estimated these reductions in cost for having a care worker come to your home and help you take care of your activities of daily living, because we knew that you would stay independent and wouldn't need that assistance. And that is in euro, millions of euro. This would be if we did it across Sweden and it was a certain age range. I don't have it on here right now, but I think it was 75 plus perhaps. We did this in collaboration with Germany, and we have some data for Germany here. I just show the Swedish. And on this one, actually I do have Germany there as well, but this was the cost for the home modifications across the country. Cost per modification, number of modifications needed based on the risk factors that we could identify in public data sets. And then this would be the total cost. It's expensive, 80 billion. To change all of these houses. But we saw that the reduction in home care in Sweden was 60 billion in 1 year. So it would take a year and a half and that cost would be made up. And then in Germany it was a little bit over 2 years, but their costs for adaptations were a bit higher. So that was part of the difference there. So again, this is just an example of how we can make some changes. And then in just trying to sum up a bit in the end here, because I'm already at 5 o'clock, these are the challenges that people face as they age. So most people want to manage independently. We also know from much research that many people want to stay in their own home. They have that meaning, but everyone doesn't. And I think that's one place where Sweden's current policies have gone wrong to some extent, is they've established these aging in place policies. So now there's often no alternative other than your existing house. And as our research showed, even if we can make the house accessible, there's other factors. Maybe I can use my house and fix my own meals and take my own bath or shower myself. But if I can't get to my friends to socialize, or if my friends can't come to me, that's not good for me either. So there's other factors to consider just than the physical environment. And I think the aging in place policies didn't take that into account. So keeping in contact with others, rebuilding. And people want to be autonomous. People want to make their own decisions. They don't want the government or somebody else telling them what you have to do. So more of a smorgasbord of options would be better. And finally, ideally, it would be nice, can we build homes for all ages? While Sweden, we have this right for a housing adaptation if you have a functional limitation, it costs millions and millions every year for Sweden to do that. In some cases, a retired person who has physical limitations will go and buy a brand new house or a brand new apartment because they want to move. They want a smaller place. They had a 4-bedroom house and all their kids are gone and they want a small place now. And they will immediately apply for a housing modification because it's not an accessible house. And then the municipality on a brand new house can spend another couple 100,000 crowns to modify a brand new house to be accessible. So if we can find a way to build homes that are accessible regardless of age and functional status, and still make them look nice. Because that's one of the complaints that younger people get, that, oh, I don't want a grab bar in my shower or in my bathtub because it looks like a hospital or something like that. So finding creative ways to make it look nice. And then I would just like to say thanks for all the primary collaborators. And thanks to you for coming today and inviting me again. Okay. Yeah.
Thank you indeed. And let's move on to the Q&A. And does someone have any questions?
Thank you so much. I'm interested in municipal administration. So I'm surprised that at least half of municipality use your research. So what is the reason for so many municipality focus on your research?
Yep. They don't all use it, but we've at least provided the information to that many. I don't have the number on how many actually use the research. But what they do in Sweden, at least once a year, they have a large conference that all the municipalities come to. So we go there. We go to them. And we rent a booth space on their floor, and we demonstrate the research that we've been doing. So I think the most recent one, we demonstrated these apps that we've been developing and showed them to them because their municipal housing offices are at these meetings. And so then they develop an interest, so we can show them that these things exist. Some of them then can choose to use that or not. But then in other cases, they actually engage in research with us. So the one project I showed you, the Tekkit Home project, where we're testing these devices in homes, there we're working with several municipalities who are helping us to recruit people for one point, but then they're also providing the services from their nurses, because they have nurses who go to do home visits for people who have dementia. And as part of their home visit, they're doing some of the assessments for us because they see the importance of finding ways to care for the family members, not just for the people with the disease. And so we approach them and we ask them to be partners. Occasionally they approach us. We have another example project that we've done in a municipality a bit north of where we are from Lund, Ängelholm municipality, where they wanted to redesign their care service, their transition of care from hospital to home. Because again, in Sweden, you have hospital care, which is actually funded and run by a region. So in this case, Region Skåne, which is that southern county, if you want to call it that, in Sweden. But then all of the home services are provided by municipalities. So they had a complete disconnect. Their systems didn't talk to each other and the people didn't talk to each other. They would send people home from the emergency room or from an inpatient stay and send them home and say, okay, contact your primary care clinic and go in next week. If you tell an older person who just came out of the hospital to do that, they're not. They're going to go home and do what they do. And when they feel bad again, then they're going to call somebody. And then we find by the time it's time to call somebody, they need to go to the emergency room again, which is very expensive. So they actually came to us and asked us to help them design a new program, which we have to some extent now, and they're actually testing it in the real world setting where they have different kind of care teams that will actually go to the home now a week after their discharge or whenever it's necessary and make sure that there's follow-up. They've started working on integrating their computer systems so they can talk to each other as well, so they can send messages directly. So sometimes we're approached, but other times we approach partners. And with this, the one where I'm talking about this new project we started with a housing company, it's a housing company we've actually worked with for a number of years. Sometimes we give them enticement. So we trained them on the methodology of how to assess a home for environmental barriers, and we did that at no cost. It's a course that usually has a fee. And then in return, they have done some data collection for us. And then they liked what they saw, so now they've continued to work on additional projects. Yeah.
Are there any other questions?
Thank you very Thank you very much for your interesting project.
Thank you.
Your project focused on temperature and accessibility as a house environment. And what do you think of the mechanism of relationship of house environment and functioning? So I think several medical markers are related to housing environment, but your project focus on more physical functioning of older age. So what do you think of the mechanisms of relationship?
Yeah, I mean, some of it is known from very controlled laboratory studies, that we know that we have this decreased strength, we have the changes in blood pressure due to the changes in the blood vessels based on temperature changes. We also know somewhat with aging, when we're dealing with an aging population, circulation changes occur naturally, so the circulation isn't as good in older ages, so the temperature can have a larger effect on an older person compared to a younger person. But what we tried to do differently was take it now and put it in a real environment, because like I said, most of these studies where we looked at that physical functioning were done in a laboratory setting, where they would put somebody in a cold room for an hour or 2 hours and then see what happens. But now I think being able to show that even this seasonal change, the cold weather outside can have an influence on it is kind of the next step. So we didn't really look at the mechanism here. We just accepted that this is occurring because we've seen it in the laboratory setting. And now we've just tried to replicate that without trying to explain the mechanisms in a real world setting. I probably didn't answer it exactly the way you would like, but that's...
Thank you very much. And one more question. I'm interested in the result of accessibility and interaction with subjective perception. So, in my understanding, from your results, people don't want to change. People who don't want to change their housing environment tend to be more lower physical functioning, right?
Not always, but they can. So if they develop a health condition that limits their physical functioning, and their housing environment is no longer as usable, we're considering how to phrase it, because we purely have been measuring an objective accessibility as we do measurements with a tape measure and so on based on a standard, and then matching that with the person's physical abilities. But we're also finding that we have this, what we're starting to call now perceived accessibility. So as I said, even if we can tell them from a measurement or a government standard that their house should be accessible, we have this perceived accessibility to say, well, I still can't use my kitchen. I can't fix my own meals. It's not accessible. But we do know that as people start to lose their functional abilities, if they don't find a way, if there's no health, there's no cure for that, they're just in a normal decline due to aging, and they don't change their physical environment to make it more accessible, then they will have a quicker decline. So once somebody starts to become dependent, they start to have a quicker decline and become dependent in other areas as well, compared to someone who is able to stop it early because we change the environment and make it more usable. And there's different reasons for that. One example being, I showed the stairs earlier, the Swedish Stairs. We haven't done this study yet, but some colleagues in the US have, where one of the answers is, well, how do you fix the problem? I mean, most houses have the living area on the first floor, and then the upper floor are the bedrooms. So we were finding a lot of older people who were turning their dining room or living room to a bedroom because they could no longer go up and down the stairs. So the first answer was often to say, okay, well, let's put in a chairlift or some way for them to get up the stairs. But that could be problematic too, because in those cases we still see a decline, because the chairlift provides no environmental challenge. So the person isn't required to do anything different. They're able to sleep in their bedroom again, which is nice. But what they found in the US was if they put handrails on both sides of the stairs, Most stairs in houses have a handrail on one side, if any. But if they put handrails on both sides of the stairs and did the change early enough, that the people would use the handrails to get up the stairs. They got stronger, and it improved their functioning in other areas as well. So they were happy because they could use their bedroom again, but then they were able to start to do other activities that maybe they had started to reduce too, because their legs got stronger and their arms got stronger from using the stairs. So they continued with that environmental pressure rather than taking it away completely. So it had a double benefit. It had that psychological benefit that I can sleep in my bedroom again and use my house, but it also provided a physical benefit. So, yeah.
Thank you very much.
Okay.
Other questions? Then one from me.
Yes?
I'm really interested about how government encourage the daily living of the elder people in Sweden, because in our case in Japan, there are the health, long-term care insurance service, which is provided for which we have the right to apply for them over 65 years old, but we have, of course, the limit of the money that we can use for the care, and it's due to the physical function, and most of the part of the care is expected to be done by the family members, but we of course don't always live with the children, or of course the wife or the husband are aging at the same time, so we cannot no more longer keep living in the place where we live, and many elderly people are waiting for getting inside the nursing home. But how about the Swedish?
Yeah. So, excuse me. So in Sweden, when I talked about their aging in place policy, that I didn't think it was ideal, part of that is because they got rid of most of these other alternatives. There are still some nursing home type facilities, but they become mostly palliative care facilities. The average life expectancy once somebody goes in those is about 6 months now. So you have to be really, really sick in order to get in one of those. So they're doing some different trials now with some intermediate type of housing, but there's not so many of those available. But many of the nursing homes have basically been taken away and closed down. So what they've resorted to then is home health services. There's no cost. It's included. Everybody's entitled, and there's no insurance. Everybody gets it. But you have to go have a medical assessment, and they determine the level of care you need. So it might be for someone might just need to have someone come and check on them in the morning and then help them to bathe or something or fix their breakfast, but then they don't come back again until the next day, where others may have somebody coming every 2 to 3 hours to check in on them. There are family caregivers as well, and it is also within the Swedish social system that if a family caregiver is providing the care and at least a physician has certified that this care is needed, that they can actually receive compensation for that time. So they don't have to just do it at no cost, particularly if they have to leave an existing job in order to do that. And that's for all ages, so if you're caring for a child as well who has a disability. But the level of care, it is dependent on your health situation, but there are no limits. So if you need, also for younger people within Sweden, if you need a personal assistance, in Sweden you have the legal right to engage in activities the same as everyone else. Everybody has that right. So if you have a severe disability, even from birth, they'll hire a personal assistant who basically is with you all the time and will take you places and do things. The interesting thing is it stops at age 65. So it's a big debate right now that these people have now lost their personal assistant that they've had for so many years, so they don't give older people the same rights as younger people, and it's a big debate going on right now whether that's appropriate or not. And we argue that, well, older people should have the same rights as all other citizens, but that's not always the case. And then the other financial aspect are the home modifications that I talked about. There's no financial limit on those either. It's whatever, you have an assessment done generally by an occupational therapist who comes to your home. They assess your physical condition, they assess your home, and then they determine what changes will be made to your home. And it's 100% covered by the Swedish social system. Did I cover?
Is that large support from the government because of you're paying many tax compared to us?
I'm sorry, it's what?
Is that large support from the government is because you pay more high tax compared to Japan?
Maybe. I don't know. How much tax do you pay? I was surprised coming from the US to Sweden that I didn't think the taxes were that much higher in Sweden than compared to the US. When you add all the different taxes together that you have in the US. So I'm not familiar with this Japanese tax system. I pay, after deductions and everything, about 30 to 33% of my income in taxes in Sweden. We have a 25% sales tax rate too, which is quite high compared to some other countries. So maybe.
Yeah. It's 8% for us for selling tax now.
Yeah. The other way Sweden is able to do it is they've really promoted dual working. So men and women all work. That's why they've started a lot of these programs for the parental leave. Rather than calling it maternity leave, they call it parental leave because both parents can take it. And so they keep more women in the workforce compared to many other countries. And so then that increases the tax base too, because you have most people, at least who want to work, working. So I think that helps a bit.
Thank you.
Yeah.
And were there other questions?
Thank you for your lecture.
Yeah,
you introduced the cold weather plan for England,
yes.
including the indoor air temperature recommendation 18 degrees Celsius. And are there any similar program or regulation or guideline in Sweden?
No, I see reference to the UK plan, but that's mostly among researchers. I mean, there's no government standard. But I think perhaps because it hasn't been such an issue, because most houses are well insulated and are warm in the winter. But perhaps people need to be aware of it, because the other thing I've found is they focus a lot with recommendations about indoor air quality, not the temperature. And they often recommend having your windows open even in the winter to have fresh air circulating through the house. There's, in many regions of Sweden, there's been problems with radon in the soil, for example. So you can get some low-level radiation through the house unless you have good ventilation going. But then also with the long winter in Sweden, if people keep the house closed up, there's more dust and so on. Most Swedes really like a lot of plants in their house, so there's a lot of pollen and other things related to plants in the home as well. So I find people, they have their windows open year-round in many cases, but usually in the bedroom is the main one people will sleep with. And in my windows in my house, I have the main window, and then next to it, it's like a little small one, about that wide, and it has a screen to keep bugs and things out, but you can open that out. That just then provides insulation. But I know when I was buying the house I'm in now, for example, it was an older couple in their 80s who owned it, and when I went in to look at it with the realtor, the bedrooms were ice cold. It was this time of year. It was January, February, and it was freezing because they opened up all the windows in the bedrooms during the day and turned off the heat to save energy, and then they don't close the windows and turn on the heat until nighttime. So it was, I mean, it had to be 10 degrees or colder in the bedrooms during the day, which they don't use them then, but it's still cold at the time they go to bed. But there's no public awareness of the potential risk of kind of going from these warm to cold environments and things in the home. But the living area, the living room and kitchen and so on, are usually quite warm. Or I wouldn't say, I mean, 20 to 24 degrees. Yeah. But I haven't seen any government recommendations on temperature, just on other aspects of air quality. Yeah.
And I have one more question about the app of the Enable Age checklist. And doesn't the houses evaluated high score in that checklist? I mean, doesn't the evaluation affect the cost value of the property? I mean, higher evaluation makes the cost higher and it makes difficult for elderly people to live in.
No, not necessarily, because when you're saying when the house is more accessible, it cost more? No, because generally if it is accessible now, it was usually done through a government grant to make it accessible because the previous owner had an issue. But we have found when they are designing new houses for seniors, because they are now starting to design some of these community apartments for this in-between housing that they're trying to make accessible, the builders have found the costs aren't that different. It costs the same to put in a ramp or put in stairs. A grab bar in the bathroom is very inexpensive. To put a grab bar in the shower or the bathtub. Most of these things, if you put them in originally, they don't cost a lot. But if you have to go in and remove existing stairs and put in a ramp or something like that, or in many cases, if you would go to a city like Stockholm or even in Malmo, they have many of these apartment buildings 4 to 6 floors high with no elevators. And to put in a new elevator there will cost 2 to 3 times more than to put in an elevator in a new constructed building. And so the costs are greatly inflated by doing it afterwards. But if the house already has it, it doesn't usually increase the property cost. A wider door doesn't cost any more than a skinny door, for example. It's usually about aesthetics, why people don't like it. They don't like to have a wide door or a grab bar. Yeah.
Okay, thank you. And a few more questions, if there are.
Presentation.
Yeah.
I have a question more about the way you're working, because you said that you're working in collaboration with a lot of different countries. Mm-hmm. And I was wondering, because each country has its own climate, its own culture and way of thinking. I was wondering, does your collaboration with those other countries bring actually answer to the issue you're dealing with in Sweden? Or each country has its own problem and has to deal with by its own?
Some of both. So sometimes we have to modify things based on the country. Excuse me. But other times we learn something that we didn't think about. And then when we actually look at Sweden, well, we have the same problem there, but we haven't looked at it or studied it yet. For this InnovAge app that I showed that we developed, we actually developed that in collaboration with 4 countries. So we did these research circles in Italy, in Germany, in Latvia, and in Sweden. And of course we got very different answers about what people thought was important to assess within their housing environment. So for example, in Italy, they hardly talked about the housing in the house itself. They talked about the neighborhood. They wanted to be able to get out and socialize and talk to people and go to the market, to be able to walk and those things. So they thought of that. And in Latvia, it was more frustration with the government agencies because it didn't seem to matter to them, because they knew even if they identify the problems, the government won't fix it. There's no money for it. So they just thought, well, this is just more cost out of our pockets. They talked more about the financial aspects of the things that it cost. But what we did in that case was we did end up with a synthesized list that was prioritized of common things across all 4 countries, and then that's how we developed the app for an initial round. So we took what they found to be most important that were the same in all 4 countries and included that. And then a next step, if we would want to implement this in other countries, would then be adding the aspects that were country specific to it. But as a first step, we find the commonalities. And so that's kind of the approach that we've used. When we did this, when they did that large housing enabler study, I wasn't there at the beginning, but I've worked with it at the end. The actual assessment tool had to be adapted based on the standards of each country. So that in that case, it was a different assessment tool somewhat in each country. So there are some modifications that have to be made that, while it makes it harder to draw conclusions on your results when you do the multinational studies because you're using a slightly different tool, it makes it more realistic for the people involved. But there are challenges with it. I mean, looking with what we're doing here between Sweden and Japan now, houses are very different. But hopefully we can learn something from each other about how to make it better for both of us. And if not, sometimes it goes one way. But as researchers, and Sweden is very much into supporting a global economy. So Sweden is very fine when we spend our time doing research that also helps other countries, even if it doesn't directly benefit Sweden, because I think they have more of the view that if we have a better quality of living across the world, then that's good for everybody. So we don't mind just helping sometimes. Yeah.
Okay, it's time for now, and I want to close this session. And thank you all for coming today, and thank you again to Dr. Steven Schmidt for today's lecture.
Thanks.